Hello, my name is Danielle Hardy. I'm the clinical respiratory specialist here at ECU Health Medical Center. Today, we're going to be going over healthcare acquired pressure injuries specific to medical devices that are respiratory related. So what is a pressure injury? The definition of a pressure injury is that they are localized damage to the skin and or underlying tissue, usually over bony prominences or related to a medical or other related devices, resulting from prolonged pressure or pressure in combination with shear tension. Medical device related pressure injury facts. So about 30 to 50% of healthcare acquired pressure injuries are medical device related pressure injuries. Greater than a third of those medical device-related pressure injuries occur on the head and neck, specifically related to respiratory devices. Critically ill patients are about 2 to 5 times higher risk due to immobility, sedation, edema, and hemodynamic instability, and their poor malnutrition status. The average cost per injury begins at about $20,000 to $70,000. Here at ECU Health Medical Center, depending on our severity of injury, the average is about $75,000 with respiratory related device injuries. This adds about 4 to 10 days to the hospital length of stay, and medical device related pressure injuries are considered never events. They're considered preventable by CMS. That means CMS does not reimburse for treatment costs. In addition, a lot of the severe cases can lead to infection, reconstructive surgery, or increased mortality risk. They're often common and costly as well as preventable. So early recognition, proactive device management, and staff education dramatically reduce the incidence and improve patient safety. The facts here at ECU Health is that a lot of our pressure injuries, they should be recorded and safe now for documentation and reporting purposes. Leadership team, along with other unit leaders, review these patients. So that means that the moment that the pressure injury, when the report goes in and it comes through our safe now, we have to go back to the day it was reported or consulted and go back 5 days prior. We review who placed the consult, whether it was a respiratory therapist or a nurse, did they communicate to one another? And we review the documentation related to the device. We review any kind of related reports, consults, or imaging. We evaluate the patient and we continue continuing education. As you can see on the right, that is a device-related injury to a non-invasive interface, and then you can see the one due to the trach itself. Contributing factors is typically poor fit or placement of the device, tight fixation, as just remember that the non-invasive interface should float on the face, moisture plus friction, the lack of frequent device repositioning, just remember that we should be repositioning our endotracheal tubes every 12 hours and then every 6 if the bite block is present. We should be doing this at shift change every 12 hours with both respiratory therapists evaluating the skin. That is the purpose of us doing that, not just to move the tube to prevent like an ulcer on the tongue. There's more to it. Malnutrition, thin, fragile, or edematous skin, which is a higher risk in neonates, elderly, and critically ill. I want to point out the edematous skin. So a majority of our patients require a lot of volume or fluid during their length of stay here with us, especially in the ICU. So if I am a post-op patient and I required a lot of fluid, 12 hours later, you might have to change out my Hollister due to the fact that I am now swelling. I am edematous. We need to be keeping a close eye on this. These are some of our Hollister or endotracheal tube related pressure injuries. Remember that we're responsible for the skin integrity of these devices. We're responsible. We do look at documentation, so make sure you're documenting appropriately and notify a nurse or the provider when noting redness, irritation, and or skin breakdown. We should be placing wound consults if they're not already active. This is just a picture showing on the left like a progression of the injury. You can see the redness of the skin, the blanching, and then you see how it progresses over time. On the right, you can see how this patient was on high flow device and then ended up intubated and now is requiring a tracheostomy tube placement. evidently is still within their 7-day time because they do have sutures in, but without seeing the circuit, I can tell you right now that the circuit is causing tension onto the skin. And I can see that because the way the flange is being pulled, the way it's being pulled away and pulled down, that is causing tension. That is going to cause some redness. These are some of just our high flow oxygen therapy interface injuries. These injuries, as well as our Hollister related injuries, tend to be some of our highest injuries with our respiratory related devices and equipment. So just remember, we can use our ear protectors, Mephilex Light as well. This is one of our recent injuries where a patient is missing part of their lip now due to the poor placement of the Hollister device. The fact that this patient went multiple days without respiratory therapists even being aware of this injury, and that we weren't performing our evaluations or our assessments thoroughly. Part of this is due to the pressure and tension on the vent circuit. Now, we're not there at the bedside all the time, but we are responsible for educating the team members that are at the bedside. So if you do see that the circuit is hanging or is being placed down, be polite, but just say as a reminder, hey, can we remember to please put this up? This could be you as a team member actually having a huddle with the nursing staff, if the charge nurse is okay with it, if the unit manager is okay with it, about how the circuit is hanging and how it should be placed. I've had several people recently comment to me in the past few weeks about this. And if you would like to do this, collaborate with your leadership team, collaborate with your assistant managers. We can do this, and I'm pretty sure the units would like for us to do things like this more often. I just wanted to highlight some mucosal membrane pressure injuries. These often go kind of overlooked just to the fact that they can't be staged, but we do end up with a lot of these injuries as well, on the lips and in the nares, just because of how that tissue is there. We need to keep in mind on that. This is part of the device care management guide on the Skin and Wound Care Team intranet page. So they have an intranet site just like we do for respiratory care. That's our respiratory care homepage. That includes our respiratory care online handbook. Skin and Wound has a page as well. They also have a policy. This attachment guide is in their policy. So Q shift, the endotracheal tube should be rotated during shift handoff to evaluate skin breakdown. Q6 if a bite block is present by the RT. The RN monitors the position so it's not pressed against lips and or tongue. We also evaluate pulse oxes. Remember that a normal neoprobe pulse ox is not to be used on the ear. There are specific ones for the ear. Recently, there was an injury. I actually had to go to the bedside for that patient for something else, and I was told that the RT is the one that put it on the ear. If the patient's got poor perfusion, you're not going to get a saturation on them. And I think that should be very clear. The unit did have these ear probes on the unit. We exchanged it with an ear probe, and the ear probe worked fine. So we just got to remember that, yes, old school, we used to do things like this, but we also were causing harm to patients. And we have to be aware of these things. Trach care, they go over trach care as well, as that's a shared responsibility between nursing and RT. Evaluate the ears when you have oxygen. Also evaluate your trach ties. When it comes to the device care management for respiratory related devices, we have to continue our ongoing assessments just to make sure nothing is too tight. Apply Mephilex Light if needed, and just continuously making sure that that is not tight and making sure we document appropriately. When it comes to specialty pulse oxes, there are rules when it comes to this. I know a lot of times we're not always the ones putting these on, but we should be mindful that, hey, the inner ear sensor has to be moved every hour, back and forth to the opposite ear. The forehead sensor has to be rotated Q2 hours as well. And that's important for us to know, regardless if we're the ones moving it or not. As far as prevention strategies for the hospital-acquired pressure injuries, just make sure that if we can transition the patient from a Salter cannula to normal nasal cannula, use the softer O2 tubing, use our Easy Wrap protectors, making sure things aren't too tight to the face, making sure that we're rotating our sensors appropriately, utilizing mask prevention such as Mephilex Light, or ensuring that we're allowing patients to have a break from non-invasive. As far as more prevention strategies, just ensuring again that nothing is too tight on the face, that we're rotating our endotracheal tubes appropriately, evaluating the skin integrity of the entire head and neck. That is something that I think a lot of people focus on, just rotating the ET tube. We are responsible for how that is around the patient. It is an actual device. It touches more than the tongue and the lips. It touches more than the inner mouth. So we have to be mindful of these things. Um, I know we get super busy. I'm well aware of that. I still do patient care, but we do have to slow down sometimes and just take a moment to thoroughly evaluate our patients. And if it's taken longer than your assessment intended, yeah, definitely put in an increment, evaluate your patient appropriately. And then specifically for the patients that do have a tracheostomy tube, we're utilizing the polymem. Remember, the polymem is allowed to be cut down if the patient does have sutures, and ensure that sutures get removed appropriately per the order. Sometimes the ENT physician might say it needs to be 10 days removed, and that's okay. They might be monitoring the patient for swelling instead of the 7 days. We would like it to be 7 days. It's not always 7 days. So just keep that in mind. Have conversations with their healthcare team regarding your patient. This is just the generic cutting guide for the Methylex Lite that's located on our handbook, as well as the OptiFlow fitting guide. A lot of times people throw away number 6, that little clip that comes alongside with the interface. That clip is really important because it prevents the tension from the tubing. So just keep all of these in mind, that the tubing, the strap should be at the crown of the head. We want to make sure we attempt to keep it away from the ears if possible. And we're going to watch a video on proper placement of the Hollister. So obviously you wouldn't let go of the endotracheal tube. You would have somebody else holding that endotracheal tube. But just be mindful about your placement with the endotracheal tube, Hollister. We are having issues, and I get that we get really busy. We have emergencies where we're really just putting it on as quickly as we can. But when we get that patient stabilized and we have them in the ICU, we should be taking a closer look at, can we move or transition to a different Hollister, or is there swelling noted? Should I reposition it? Do I need to change it out? Yes, if appropriate, change it out. Because the thing is that these wounds and the uptick that we're having recently with the two recent large wounds, or the severe wounds that we've had, have came from the Hollister, and they were due to poor placement, or they were due to the fact that we didn't evaluate the patient appropriately. And I say we because we're all one team. It doesn't matter if I was in there, it doesn't matter if it was Ken in there or Brandy, whomever. It matters that we're respiratory care and that we need to pay attention to what we're doing with our patients. There are times we're busy, but we just need to be mindful of these things. So the Skin and Wound team does have an intranet page. As I shared before, they do have some skinny on skin or standardized unit education for monthly updates on their page as well. They also have a policy and policy stat that is system-wide. And again, this is that wound consult order that we're allowed to place. We do have a Skin and Wound champion in the adult service line for respiratory care here at the medical center. That would be Anna Faso, David Ivy, Jessica Baker, Keenan Michael, Christy Garcia, Macy Manuel, Paul Koo, Rochelle Butcher, and Stacy Howard. Brenda Andrews has signed up to be a Wound Team Associate member, which is part of the program that Skin and Wound offers here. If you would like to be a part of that program and complete the modules to have that on your resume, or if you would like to join the Skin and Wound Champion team, just let myself know, or contact Brenda if you're interested in that WTA program. As far as the Skin and Wound Champions, they assist in education with me, as well as performing audits, 5 patients a month, and just doing bedside education as well in real time. And these are references for this presentation. So the purpose of this presentation is, annually we tend to have issues when it comes to pressure injuries. Unfortunately, we've had 2 really large severe wounds recently, and that cost the hospital a lot of money. So we have to annually just remember that, hey, we've got to do education on this. We need to pause for a moment, use our safety habits, and peer check and peer coach when needed. We need to make sure that we're evaluating patients appropriately. We need to slow down. Sometimes we get to moving so quickly, or we get to moving so routinely, and we just want to highlight some of these issues. There will be a quiz that you're going to have to take with this education. This is going to count as the October education for the adult side, and it's due October 31st. I hope you all have a great day, and please contact me for any questions.